Next speaker is Tanya Doherty, who is a chief specialist scientist, is that right? At the Medical Research Council, and she's going to give us an overview of community health workers and its context in South Africa. Thanks.
Good afternoon, everyone. I'm Tanya Doherty from the South African Medical Research Council and the School of Public Health at UWC. I'm going to give a very brief overview of community health workers and their role in child health, with some implications for South Africa. So why should we be having a community-based delivery platform for child health? Well, many child deaths occur outside of health facilities. We heard from Professor Makera yesterday, as many as 52% of child deaths in South Africa are occurring at home. And currently the coverage of many effective interventions for child survival is low, in many cases under 50%. We have good examples in South Africa of our coverage of exclusive breastfeeding and oral rehydration solution for children with diarrhea, which are well under 50%. We know that children from poor families and those living in rural areas are less likely to access health facilities than those from wealthier families and those living in urban areas. Catherine Hall shared with us yesterday that 32% of quintile 1 households travel more than half an hour to reach a clinic in South Africa. So why has there been a renewed interest in community health workers globally and in South Africa? Well, there are many compelling reasons for this. We have an acute shortage and maldistribution of health workers. It's estimated that there are around 32,000 vacant posts for registered nurses in South Africa. We have increased requirements imposed by HIV, and the forthcoming universal test and treat policy is going to place additional strain on our health workforce. And together with this, we have a growing epidemic of chronic non-communicable diseases. We've been through the pressures to reach the Millennium Development Goals, and now we face the Sustainable Development Goals, all of which place increasing strain on our health services and health workforce. And there's been a renewed interest and a focus on primary health care, universal health coverage, and the important role of communities in health. Looking at some policy shifts in the management of childhood illness, in 1997, WHO and UNICEF endorsed the Integrated Management of Childhood Illness Strategy, and this was followed very soon after, in 1998, by the community component to IMCI, focusing on preventive and promotive family practices. Over the subsequent decade, the implementation, the funding and support for IMCI waned, and we've seen stagnant coverage of interventions for the major causes of child death, as well as large equity gaps within countries. And in response to this situation, in 2012, WHO and UNICEF endorsed integrated community case management. So ICCM is a disease management algorithm which has been adapted from IMCI. It includes prevention and promotion through key family and community practices. Community health workers are trained to assess and treat children with pneumonia, malaria, and diarrhea. They're trained to refer serious or complicated cases to first-line health facilities. They're supervised by IMCI-trained staff and are supplied by health facilities providing IMCI. In sub-Saharan Africa, there's been a huge increase in the number of countries with ICCM policies. In 2013, 28 out of 42 countries in sub-Saharan Africa have policies enabling community health workers to treat malaria, pneumonia, and diarrhea in children under 5. And 6 countries in 2013 had policies enabling community health workers to treat neonatal sepsis. There's a wealth of evidence for the impact of community health workers, and I don't have time to share all of it. But there is a systematic review showing impact for community health workers on increasing coverage of immunizations, of exclusive breastfeeding, and of pulmonary TB cure rates. But the focus here will be on pneumonia and training community health workers to identify suspected pneumonia through fast breathing and chest indrawing, provision of oral amoxicillin, and training parents to recognize danger signs, has been shown in a meta-analysis of trials from Asia and Africa to result in a 35% reduction in pneumonia mortality and a 21% reduction in total mortality, with the largest impact being seen amongst neonates. We also have evidence showing that community health workers can perform as well as or better than nurses in first-level health facilities. This data is from Ethiopia, where their health extension workers provide care for children. And this study has shown that the health extension workers were able to perform key assessment tasks and to correctly identify a child with an IMCI condition better than nurses, and that they were able to treat a child with pneumonia and identify a child needing referral as well as the nurses. There's a huge amount of evidence for the impact of community-based newborn care. I'm just going to share one example of a trial that we undertook in South Africa, where a package of 2 antenatal and 5 postnatal home visits led to a doubling in the rate of exclusive breastfeeding at 12 weeks, and the impact was seen amongst both HIV-positive and HIV-negative mothers. The trial also had impacts on secondary outcomes, including mothers making preparations for delivery and mothers attending a clinic visit within 6 days postpartum. A meta-analysis of 9 trials from Africa and Asia has shown that a home visit package by community health workers can lead to a summary reduction of 21% in neonatal mortality. There are several high-burden under 5 mortality countries that managed to achieve the MDG4 target. Increasing access to care through community-based delivery has been key to success in these settings. Here you see the under 5 mortality rates for South Africa, Brazil, Rwanda, and Ethiopia. Brazil started at an under 5 mortality rate and the MDG baseline similar to South Africa, and by the end of the MDG era had achieved a reduction in the under 5 mortality rate to 16. Rwanda, starting at a baseline of 152, reached the same under 5 mortality rate as South Africa in 2015. And Ethiopia, starting on a baseline of 205, exceeded its MDG4 target ahead of time with an under 5 mortality rate at 59 in 2015. All 3 of these countries have policies enabling community-based treatment of pneumonia. So what contributed to the success in under 5 mortality reduction? Well, Ethiopia focused on increasing its human resources for health, including health officers, nurses, and most importantly, they employed a cadre of health extension workers, over 34,000 for the country. And they built over 16,000 health posts where these health extension workers operate from. Brazil, an upper middle income country similar to South Africa, focused on reducing regional and socioeconomic inequalities through its family health program, and community health workers are the main providers of care in this family health program. Brazil managed to reduce its under 5 mortality across all regions of the country, including the poorest, most remote north and northeast regions. And coverage of the family health program has been critical, particularly for the poorest municipalities in the country. Brazil also managed to reduce stunting, most importantly amongst the poorest families, with stunting rates in the poorest income families reaching those similar to the wealthiest families by 2007. So where can community health workers make a difference in South Africa? Well, our MDG4 era has been termed by some to be a successful failure. Whilst we did turn the tide in under 5 mortality through the introduction of PMTCT, we did not come close to reaching our MDG4 target. And whilst we have a success story in increasing the coverage of PMTCT, this did not occur within the context of generalized strengthening of our child health services. And so the implications of a singular focus on elimination of HIV have meant that avoidable deaths due to pneumonia, diarrhea, and neonatal causes are now the leading contributors to our under 5 mortality. South Africa has seen very little change in the contribution of pneumonia to under 5 deaths. And a recently published study, a mortuary audit of deaths outside of hospital, has found that lower respiratory tract infection was the leading cause of death in infants and children 1 to 4 years old. Amongst neonates, lower respiratory tract infection contributed over a quarter of these deaths, and child abuse and neglect was an important contributory factor. Most of these newborn deaths were amongst infants born prematurely, and they died soon after discharge from hospital, a prime opportunity for community-based newborn home visits. We have ongoing large inequalities in access to care, with a more than 20% difference in coverage of a postnatal visit within 6 days between our most deprived and our least deprived districts. Our early inpatient neonatal death rates are higher in our most deprived districts, and delays in seeking care, low maternal knowledge of danger signs, and poor quality of neonatal care at district hospitals have been identified as important factors. The highest rates of early neonatal death are seen in Limpopo, the Eastern Cape, and the Northern Cape, provinces with large rural populations where community-based services are critical. So we certainly need to do things differently. South Africa, as an upper middle income, relatively wealthy country, has health outcomes for children far worse than Rwanda and Bangladesh. We're starting to do things differently through our outreach team model. But our community health worker roles in South Africa focus entirely on assessment and referral with no curative functions. There's wide variation in remuneration, conditions of service and contracting, and scope of practice across the country. A case study of implementation of ward-based outreach teams in the Northwest Province has found that clinic managers were not fully owning the strategy, that community health worker remuneration was low, and that there were strains on local clinic infrastructure. And importantly, we hired our team leaders from within existing facilities, further increasing the burden on the few staff that we have within our primary healthcare facilities. The density of community health workers is absolutely critical for impact. Brazil, with a population of 200 million, has 235,000 community health workers. That's 1 CHW per 150 families. Rwanda, with a population of 11.6 million, has 45,000 community health workers, 1 CHW to 260 people. So with a population 1/5 the size of South Africa, Rwanda has a similar number of community health workers. And if you take into account that most of our community health workers are not full-time, that difference is even larger. So the ratio of community health workers to population is absolutely critical for impact. This slide is showing from nutritional outcomes. In Senegal and Ethiopia, where there are around 80 community health workers per 1,000 children, they've managed to achieve a 2 percentage point reduction in underweight prevalence per year, which is far higher than countries with a lower ratio of community health workers to children. So the current WBOT strategy and CHW program in South Africa will not result in desired reductions in child mortality without firstly extending their scope to include some curative functions, and secondly, improving the ratio of CHWs to households. To reduce newborn and child mortality will require both increased numbers and skills of CHWs, as well as greatly improved clinic and district hospital quality of care and functioning. South Africa needs more CHWs who are allowed to do more. Thank you.